Ethical Perspectives on the News is produced by the Interreligious Council of Linn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Welcome to Ethical Perspectives on the News. I'm Bob Rush. Today we're going to be discussing an issue very close to all of us, end-of-life decisions, and how one goes about approaching those, what the options may be. We are very fortunate to have two panelists today that have extensive experience in the area. Dr. Rebecca Benson at the University Hospitals and Clinics is director of the Pain and Palliative Care Program, among other things. Dr. Rebecca Thoman is with Compassion and Choice, and we will be asking each of these doctors to share a little bit more about their backgrounds before we get into our substantive discussion. Dr. Benson, would you go first, please?
Certainly. Thank you for inviting me to be a panelist. So I'm a pediatrician by background and hospice and palliative care medicine specialist. My other area is ethics. So I'm on our hospital's ethics consult service and the clinical director for ethics here at the hospital. So as a palliative care doctor, I'm very interested in helping people navigate the end-of-life journey and their experience with serious illness in general, helping to alleviate suffering and make meaning out of the time that people have with their loved ones. So I think this is a great topic for us to be discussing as it's ever evolving and emerging, and I look forward to our ongoing discussion.
Thank you. Dr. Thoman.
Hi, yes, I'm Dr. Rebecca Thoman. I was trained in family medicine. I do not have a clinical practice. In the last 2 decades, I've been in the world of public health policy, and I've been with Compassion and Choices for the last 8 years, working to bring medical aid in dying as an end-of-life option to patients. And we also work, in general, our goal is to improve care and expand options and empower people to have the best death they can.
Thank you. It's been nearly 30 years since Oregon passed legislation creating the Oregon law that has been a foundation for other states. I think there are about 9 other states that have similar statutes. Is that correct, Dr. Thoman?
10 states plus DC.
Plus DC. And I've tried to do a tally internationally. There are at least a dozen countries, it looks like, that have euthanasia authorized in their respective countries. Dr. Thoman, let's first talk a little bit about terminology, please, because we get sometimes the language gets askew.
Sure, thank you for that. So a lot of people think of the term death with dignity, which is actually the name of the Oregon law. It's the name of the Washington law. But the actual practice is, by statute, is defined as medical aid in dying. And it's a very, very specific practice that applies to a terminally ill adult who is within 6 months of the end of life and has full decision-making capacity and the ability to self-ingest a medication. And so it would not be something available, for example, for someone with Alzheimer's disease. But these people then would, if you qualify and 2 physicians agree that you qualify, then you can ask and receive a prescription medication that can be then ingested for a peaceful death. And like you said, Oregon has been doing the practice for 23 years. And we're now up to about 22% of the population now lives in a jurisdiction where this is available. It's not euthanasia, and I like to clarify that because euthanasia is what we do to our pets, right? We give them an injection that puts them to sleep. There are no injections in this as it is practiced in the United States. It's completely patient-driven And the individual must ask for it, decide to do it, and if they follow through, they must ingest the medication on their own. So it's completely driven by the individual. There's no substitute judgment, and there are no injections.
Okay. And Dr. Benson, any further comments on terminology? And
Yeah, I would say that other people may have heard of this as physician-aided suicide. Again, that's not a preferred term anymore because suicide has certain connotations that are not necessarily helpful in this context because it's people who have a terminal illness and are already at the end of their life, and it's not necessarily due to a desire that their life would end early, but knowing that their life is ending early and wanting to have a specific amount of control over that. So I think that term is used less often. Physician aid in dying is another term that's very commonly used in the medical literature in the United States. And medical aid in dying is a nice broad term that I think encompasses this. And in other countries, however, it may also include voluntary active euthanasia, such as in Canada, which is a slightly different practice that's not practiced here in the United States. But I think medical aid in dying or physician aid in dying are the most helpful terms to use.
Thank you. Dr. Thoman, generally, how do these American state laws work?
Well, it's pretty straightforward, really. The individual patient has to qualify. So as long as they're an adult with a 6-month prognosis, and generally that is the same as we would consider for hospice, although it's not a requirement that they be enrolled in hospice. Most patients, in fact, are enrolled in hospice who use medical aid in dying. Then they would simply go through a series of steps. They would make a verbal request, a written request. They'd be evaluated by 2 different physicians to be sure that they qualify, that they have full mental capacity and decision making. And then if they do qualify, in some states, there's a waiting period where a person might have to wait anywhere from 48 hours to 15 days before they can then receive the prescription. And then it's basically on their time frame as to when they want to ingest it. It's most often done at home. Families are very involved. It's a very planned out procedure. And then the pharmacists create that they actually mix a 4-drug mixed cocktail. And the person then does a little bit of a prep. They will have only liquids for a while. They'll take an antiemetic or something to help prevent vomiting. And then they will blend and take the medication. Usually it's in a powder, mix it with a liquid. It's kind of nasty tasting, so they have to be ready for that. They drink the medication and they fall asleep. And the times vary, but I would say between 2 and 5 minutes. And then their breathing and their heart rate slow and stop within 30 minutes to an hour. Although there are outliers who may take a number of hours. This is what's average. And as the combination of drugs has evolved over the years, they're getting better and better at absorption that puts a patient to sleep quickly and then allows them to stop their heart and lung and fall asleep and then stop breathing.
Dr. Benson, for our viewers' sake, does Iowa have anything like this?
Iowa currently does not, although I believe that bills have been introduced to Congress within the past year or two. So it is part of our discussion in the state now. I think what we're also really focused on is making sure that people have adequate access to palliative care and hospice care, because for many patients, while this is something that they may request and may want to talk about with their physician, even if they're in a state where it's available and they request and are given the medication, not all patients use it. So it's also very important to make sure that we are giving them good interdisciplinary palliative care by use of social workers, chaplains, other people who can identify different areas of suffering that may be happening at the end of life and try to alleviate that, so that really they do have the fullest range of options available to them. And I think that that is something I just want to make sure that we emphasize, because I don't want the emphasis to be on going to a doctor to get a prescription, when really we know the best kind of care at end-of-life care is interdisciplinary care that supports the whole person and the family in the context of the end-of-life setting.
How do we know that?
I'd like to agree with her 100% and say that, first of all, hospice care is the gold standard. We know when people go to hospice care or enroll in hospice, they feel better, they live longer. And in fact, most of the people who utilize medical aid in dying are enrolled in hospice care. And hospice care certainly provides a peaceful death for the vast majority of people. So we're really talking about a small group of people. I would also agree that just having medical aid in dying as an option has been shown to improve communication with patients and doctors, easier to talk about death. We find that even just knowing that it's an option will ease patients' fear or anxiety about suffering. So just having the availability of the option does, in fact, it's palliative in and of itself. But I totally agree that this is not a first option. Patients should be getting into hospice care, maximum care, so that they are comfortable and are living the quality of life for as long as they can. This is an option for some people, and I will say that a pretty typical profile of someone who chooses this is a patient with an end-stage cancer, ovarian cancer, bladder cancer, esophageal cancer, where it's very clear that they are coming to the end of their life and they may have really significant symptoms from which they are suffering. The other category of patients who tend to use this are people with neurodegenerative disorders like ALS. Again, the trajectory is fairly predictable, and this is one way that they can avoid those final weeks of suffering. So I agree that hospice is the gold standard, and that we want everyone at the end of life to have access to and utilize hospice care. There are annual reports collected by the Department of Health that gives data on things such as how many people requested the medication, how many received the medication. And it's a very common now and recurring theme that about 2 out of 3 people actually do ingest the medication. About 1 out of 3 do not. We don't know why. We don't know whether they just changed their minds, they didn't need it. That is not tracked, but it is a truism that is very repeated around the different states, that about 1 out of 3 end up not using it. And so we do think there's a palliative effect just knowing that it's available.
And Dr. Benson, does organized medicine like AMA and Palliative Care Association physicians, do they have a position on this issue?
That's been evolving over the past several years as well. The American Medical Association, or AMA, is one of the places that really puts forth a code of ethics for physicians. And it has fairly consistently said that medical aid in dying is something that it has concerns with, because it is not considered to be part of the healing profession that we are in. However, it recognizes that there is a diversity of backgrounds and beliefs among both its members and the general population that we serve. And so I think more recently it's becoming more open to discussions that are ongoing, but there are definitely concerns about whether this could impair trust with the public, because while some people, patients and their families, very firmly desire for this to be an option, other people may feel that it impairs their relationship with their physician if they feel that their family or other people may be able to coerce or encourage them to end their life early. There are some significant concerns, and also based on the expansions that other countries around the world are doing, that there may be slippery slope topics. So I think it's something that the AMA is keeping a close eye on. The American Academy of Hospice and Palliative Medicine is one of the big organizations for palliative care and hospice clinicians, and it kind of has a neutral stance. It's continuing to allow members to have discussions and to provide guidelines for how to have conversations with patients who bring this up, because it's very important that if somebody brings it up, that we have a thoughtful and empathetic and supportive conversation with them about what it is they're concerned about and what it is they're looking for, and how we can best provide for their needs. So there are a lot of guidelines to help support have that conversation, but it is a bit neutral in terms of stance at this point, I would say. And I don't know if Dr. Thoman has other comments on that.
No, I think that's a perfect characterization. And the other large group that has, the way I describe it is they've sort of shifted away from the historic opposition that they've had to a more neutral stance. So the largest, the American Academy of Family Physicians, has moved to this neutral stance, and I would characterize it as being neither for nor against medical aid in dying in principle, but recognizing that their members, like the public, are not all in agreement, but that they want to be sure that there are safety parameters around it, so they stay engaged in the conversation. And then within those guidelines or those boundaries, patients and doctors make ethical decisions. And the data, the surveys of physicians pretty much echoes the feelings of the general public, which is about 55 to 65% would support medical aid in dying as an option. About 25 to 30% are opposed. And then there's that sort of middle group that's maybe, I don't know, and it depends.
As a recovering politician, I'm always interested in the numbers, and New Zealand was the most recent vote that I could find where there was a referendum to authorize euthanasia, and 65, nearly 2/3 were in support of that measure. So let's move to what the arguments have been against this option for competent adults. Dr. Benson, you want to start?
Sure. I think the arguments against have been that to prescribe a medication that is intended to end life is felt to be something that is maybe against the Hippocratic Oath. For example, we strive to do what is in our patient's best interest and to not harm them. And most people would agree that death is a kind of harm. In these unique cases, death is going to happen anyway. And so people would argue that this is giving more control and choice over how that happens. But I think that has been really the biggest argument. And the arguments have been for using other strategies such as palliative sedation, which is a type of treatment that focuses on treating distressing symptoms. So if somebody has really severe pain or breathlessness or seizures, that you're very focused on the symptom that you're treating. And if you have to get to high enough doses that it may shorten someone's life because of sedation and they stop eating and drinking or their breathing slows down, then what your intent was to assist with their symptoms. And so the intent was good, and so the overall action is felt to be good. Whereas the intention to end a life is more concerning to a lot of physicians and also people in the general public. So that's my understanding of one of the major arguments against medical aid in dying.
Dr. Thoman, your comments, please.
I would agree that I think for many who object, first of all, I think there's a lot of misinformation and lack of information that makes people suspect or question it. But I do think that largely it would be a religious or moral objection. So it individually offends them as physicians and their role as physicians, or just as individuals who feel life is sacred. So that's really the argument that it comes down to. And there are lots of people and physicians who would say, you know, we deal with death as part of our work, and we help people die in many ways, and we never try to harm them. But for example, in states where medical aid in dying is not available, cancer patients may, at the very end, just say, I've had it, I'm going to stop eating and drinking. And that's perfectly legal. And it may take them 7 to 10 days, and they'll stop eating and drinking. They'll receive some medical support through that process. But, you know, and some would say they're sort of equivalent. It's just that one, we have the medication to make it more peaceful and easier on the families. So it really comes down to your perspective and how you view something from a moral or religious code.
Colorado in recent years passed legislation similar to Oregon. I happened to attend a symposium in Colorado, and during the Q&A, one physician got up, identified himself as a physician, and he said, I wish this law had been here for one of his patients. He went into some detail. He said the patient ended up using a shotgun to end his life. Another person got up, said, I'm a physician, and everything I believe in is keeping the patient alive. So I guess that's the debate that we are encountering.
And I think that is part of our training. I mean, historically, that's what doctors are trained to do. So to kind of change this whole conversation, which is driven by the field of hospice and palliative medicine, to take another look at our relationship with death and our role in helping patients who are going to die, to do that, to have the best quality of life, you know, and die peacefully. It's really a whole new world. And the hospice and palliative care doctors are leading this effort.
And I think that I agree that one of the real challenges is the idea of hastening somebody's death or putting it on our timeline instead of, you know, those who have a religious faith that would say it should be on God's timeline. I think that can be a big argument or challenge for some, and those of us who are present at births and at deaths realize that despite all the planning we can do and all of the control we try to have, that there are things that happen on their own timelines and that take the time they take. And so it is a challenge, and some people find it to be morally not something that they can participate in, to consider hastening someone's death. I think the other side of that coin, though, is that we do so often do things to prolong someone's life when we know that they are not likely to have good quality and much time left. There are so many things that we do to sustain their organ function or provide nutrition and hydration that wouldn't have been able to happen decades ago and that really affect the dying process. So I think it's an interesting relationship that we have with death these days, and are trying to work our way back around to having both the respect for it, but also understanding of its timeline and how we can affect that.
And Dr. Benson, you would probably have this data at your fingertips, but I think the average length of stay in hospice is fairly short. We're talking 14 to 21 days, which sort of demonstrates that we're treating, especially in the cancer field. And so we're trying to stave off death, but what kind of suffering are people enduring because of that? And are we really giving them options? So there's a lot of change that needs to happen.
Has there been any follow-up study as far as family, loved ones who have watched a loved one in palliative care and their body shuts down, as to the effect on those individuals that have witnessed that? Any studies out there?
some of the studies that I remember hearing about talk about if family members knew what the loved one wanted and were able to support their preferences and values at end of life, that gave them a lot of reassurance and helped their grieving process to go better. So I think that emphasizes that it's so important to have these conversations, and we can't always plan for every scenario that might be ahead, but we need to keep having conversations, especially with those who are experiencing serious illness, so we know what they would want if they can no longer speak for themselves, and that we know what options they want to be available to them.
And in those states that do permit assistance, you can't have it has to be the person his, hers, or herself that says, yes, this is the path, I want this option. It can't be some stand-in family member. Is that right?
Correct.
Yeah. What if somebody's in chronic pain? Is there any option for that person under any of these laws? Are they simply dealing with somebody who's got 6 months to live?
Yes. Medical aid in dying is strictly only for people who have a 6-month prognosis. So the hospice criteria. So they have to have a terminal disease. This is not something for ongoing chronic pain or disability. It's strictly for terminal disease.
Other countries have expanded that, and I think that that's one of the things that makes people want to proceed with caution, because other countries have made it available for those with depression or who just don't want to live anymore. So I think that's one of the reasons that we have tried to advocate for keeping this to those patients who are already experiencing the dying process.
Thank you, doctors. We have just 2 minutes left, and I would ask if you have any closing comments, Dr. Thoman, to begin with.
Yeah, I'll just make one quick point that I think is really important, which is I think 25 years ago, 30 years ago, when Oregon was first taking up this law, there was a lot of concern about how the law would play out. Would poor, disabled, minority people be coerced or forced into using this as an option? And what we have found is it's the exact opposite. It's really become a white upper middle class privilege. And that's in part because there are no government programs that insurance will cover it. So Medicare doesn't cover it. The federal portion of Medicaid does not cover it. VA does not cover it. Any government employee health plan doesn't cover it. So unless you have private insurance that will cover it, people have to pay out of pocket. And so there is, if you look at like who uses this, it tends to be white, well-educated people who have insurance. And so that's really something to look at is there some real disparity in access?
Dr. Benson?
Yeah, I would just say continue to have conversations with those who you love and with those who are in serious illness, so that you know what's important to them, and really utilize all the resources that are available through palliative care and hospice, including spiritual services, social work, things like music therapy that can really add quality to people's lives. And
Doctors, thank you very much for your insights, your observations, and for what you do every day. We appreciate it. Thank you for joining us.
Thank you.
Thank you.